as where she did her transplant training. She just had to remind me all these things. So I think the exciting thing about transplant, not only are they increasing their numbers, they're improving outcomes, but they've also started doing some research projects looking at people who have aortic stenosis and their outcomes after kidney transplant. And I know that they're starting some research on looking at hepatitis C, recipients of hepatitis C kidneys, recipients of hepatitis C kidneys, and looking at their outcomes also. So pretty exciting stuff happening in kidney transplant, and Lina has now named herself a transplant nephrocardiologist and will give us a journal club. Thanks.
Didn't expect such an official introduction.
Make sure everybody silences their phone. I forgot to please say.
Please silence your phones.
Thank you.
You don't have a New York accent.
No, I'm from East Kentucky. I keep telling patients that. like everybody, it's actually really funny. I'm not ambitious at all, but I feel like I am becoming a nephrocardiologist, so a little bit of a cardiologist. And the other day, and now I feel much more confident actually talking to cardiologists. I call them, and it was one of the cardiologists that I've never interacted with, and he acted as if he how they act. You have no idea what you're talking about. But then I have all my data, and I'm not trying to show that I know everything. I'm just trying to really make sense of for the patient, and so that they don't die during the transplant. And then at the end, he became more humble. So I'm feeling if they start talking to me and not feeling like they know it all and listen to me, I feel like I am becoming a nephrocardiologist. So it's a journal club, but I'm not going to jump right to the article, but I'm going to say why I did this article and what prompted me to actually research this topic. So first of all, why are transplant nephrocardiologists needed? Which I think could become a real thing. The cardiovascular death is the most common cause of transplant patients dying after transplant. That's within first year, within first month, 5 years after transplant. So they die of heart disease, period. And we don't want them to die, especially early after transplant. Cardiologists are so used to giving cardiac clearances for surgeries. This is how they make money. They bill quickly. They do the tests. If they can do the cath, it's even better. And that's how, just any cardiologist will approach the kidney transplant workup patient the same way. Before I learned it hard way, that this is not the right way, I've burned many times where the patient was cleared by a cardiologist for kidney transplant, and boom, they die of a heart attack or heart failure 2 days after the transplant, or their kidney doesn't work. So the clearance for kidney transplant from cardiology is totally different than clearance for, let's say, cholecystectomy or cancer surgery or anything like that from the cardiologist. The problem with cardiologists are they tell me what is their risk of dying from cardiovascular, from heart attack perioperatively. They say continued beta blocker and things like that, but nobody ever thinks that the person is actually getting a new organ, a kidney, which will have to work afterwards and will have to be perfused, and that it will need good hemodynamics in order to start working. The other thing is you don't want to miss something that will have to be fixed in the near future. So I had patients who had some valvular disease, let's say moderate aortic stenosis. They're doing fine on dialysis, they're asymptomatic. It's impossible to convince a cardiologist that this is going to be a problem after kidney transplant. So we've had people who got kidney transplants with, let's say, aortic valvular disease, which didn't qualify for surgery at all. And cardiologist said, "Are you crazy? Worrying about it? Just just go ahead and do it." And then they needed valve surgery like 2 months after their kidney transplant. There is actually evidence and studies and publications about really high mortality in kidney transplant patients if they are undergoing any cardiac surgery within the first year after transplant. The mortality of undergoing a cardiac surgery is much higher compared to ESRD patients for undergoing dialysis. So we want to absolutely avoid it because we're going to lose the organ and then the patient is going to do poorly. This is one example. This is a real patient and this is her real initials, and I only realize now what they look like. So patient BS, but it's just her initials. So she's a very nice lady. Love her to death, and she very nice people. And I just saw her in the clinic 2 or 3 weeks ago. She's 76 years old, Caucasian lady who has history of hypertension and ESRD from lithium toxicity. She's so nice. That's another thing. I don't even know why she needed lithium at any point, but she received cadaveric kidney transplant in 2017, and it was unblocked pediatric kidney transplant, which is a really good thing to get. Post transplant course, she had a history of coronary artery disease. She had a stent in 2012 and in 2016, but her cardiac cath was clear before the transplant. I saw her in the clinic, 12/1. She was having a lot of swelling. She was having worsening shortness of breath with minimal exertion. And she had a visit with her cardiologist about 2 weeks ago. And she was complaining of the same things. And her cardiologist did like all workup that could be done. So he did TEE, not sure why not transthoracic, but her ejection fraction is fine, 56. She has grade 1 diastolic cardiomyopathy, which is not too bad. Her RSVP is 74. Good, bad? A little bit high? Actually, it's kind of, sort of very high. And she has severe TR. He did do left heart cath, and she has no new coronary artery disease. He didn't call me to ask if it's okay to give a dye. So on my bad list. And he did a right heart cath as well. So her cardiac output is 6.15 and her cardiac index is 3.8. Her PA pressure on the right heart cath was a little bit better, 58/22 with a mean pressure of 38. But still high, right? So the mean pulmonary pressure should be somewhere around 15. So if you go by the classification, up to 25 is mild pulmonary hypertension, 25 to 50 moderate, and 50, more than 50 severe. So she's in the range of getting closer to even severe.
What was her EG?
Oh, her creatinine is 0.5. 0.5. Mm-hmm.
So that's why he did that.
He did right heart cath after he started her on some diuretics, so it probably improved from that TEE because she got diuresed. And I didn't put that here, but whatever number, like when you look at the right heart cath results and you have this high PA pressure, which I look a lot now, what else do you look at to get like a full picture?
You're asking me because
everybody. Yeah.
Well, I was going to say the reason that so somebody in the lab drew a serum creatinine before the procedure. They just checked the box and said her EGFR is high enough. You don't need to worry about it.
Well, the cardiologist very well knows that she has a kidney transplant.
But he just all he knows.
Yeah, but of these numbers, you need a wedge. So, because that will tell you if she's just volume overloaded or she has actually pulmonary hypertension. So the difference can be like if the difference is more than 8, it's not only volume overload, it's also pulmonary hypertension. So she had both volume and pulmonary hypertension. I guess I'm not going to quiz you that much. I'm not going to torture. But the bottom line, this lady has a AV fistula. It's huge and it's getting bigger. It's like, whew, like this. And the cardiologist didn't pay attention to that. So from just anecdotal, experience and from my past dealing with patients like that, I like right away thought that does she need the ligation of this fistula, and I called the cardiologist, and then he was very surprised that this can happen and that this ever works in the patient. Mm-hmm.
What was her cardiac output?
6.18. So normal is 4 to 8, 4 to 7. So she's on the high side, and her cardiac index is actually on the high side as well.
So she's shunting.
So she has from the fistula, yeah. So from her megafistula, she has a state of high cardiac output state, and she has increased pulmonary flows, so increased pulmonary hypertension. And her TR, I'm pretty sure part of it at least is from her volume overload and from her pulmonary hypertension and from shunting. Mm-hmm.
What's the normal flow rate?
It is, 1 to 2 liters per minute. I looked it up.
So that's no different.
For her fistula?
For her fistula. So normal.
I don't know what her fistula. I didn't check her fistula flows.
Normal blood flow through.
I googled it. So see, you have to believe me. So what are the hemodynamic effects on a patient with AV fistula? So AV fistula, it is a significant left to right shunt, and the blood flow rate is 1 to 2 liters per minute. That's what I found from looking up that. And it is known and it is well documented in the literature that it is associated with left ventricular hypertrophy, with ventricular atrial dilation, increased pulmonary flows, and increased cardiac output. The other thing is that I always tell patients, residents and the nurses, everybody freaks out, especially in ICUs. People who have big fistulas, they have really wide pulse pressure. And in ICUs, people set goals for mean pressures when they put them on pressors. And then, you see this ridiculous thing, like the patient with megafistula and their systolic is like 170 and their diastolic is 50. And the nurses keep increasing their Levofit dose and we can't reach that map, So sometimes I feel like in these people also, it's just a sideline. Sometimes maybe we need to set like the systolic goal, not the mean. Now, since I have been talking about all these pressures, and I think I look a lot at this, especially in patients in CV ICU and in ICU. It's good to to know what the cardiologists and ICU doctors know. So the normal pressures in the heart. So a right atrium less than 5, then right ventricle they don't show that on the monitor, but pulmonary artery systolic 25, less than 25, diastolic less than 10, but mean 15 or less. Wedge 12. And then we know systolic systemic pressures, what the normals are. And this is like in CV ICU or in ICU, a lot of times this is what people have on the monitor. So I always go through this with the residents, and because it's very helpful. So the yellow thing usually tells the pulmonary pressures, and you had the mean. So sometimes, what is really helpful is tracking the means throughout the day. So like writing out in your notes, like what's the trend? So, do you push more diuresis? Are you lagging behind? Do you dialyze more? It's very helpful. The patient has to be like leveled though. They have to level the monitor to their, right atrial level. So sometimes new nurses don't know, and there's plenty of new nurses. But this is very helpful. Then CVP, I never talked to Dr. Cavalazzi about this because he doesn't believe it and gets like frustrated. They look at it, but they definitely look at it at 3 East. And okay. Oh, so I'm getting to my article, what I'm supposed to do. So I did a little bit of the research. There are case reports where they show that ligating the fistula improves the kidney function in patients if they have megafistula or if they have pulmonary hypertension. But this is actually a neat study. It was done in Australia. I think in Australia they have more like uniform medical records, so they can do like a better. But but it is actually a prospective randomized study. This looked at the effects of AV fistula ligation on cardiac structure and function in kidney transplant recipients. It was published in Circulation. So this is like American Heart Association official journal. So it's, I guess we should trust it. And it was a randomized control trial, prospective. I think they planned it pretty good. Like I didn't see like many flaws in it. They only included kidney transplant patients who had kidney transplant more than a year ago. The reason why you don't want to include people who have had kidney recently is that actually left ventricular mass decreases during the first year after transplant because the uremia clearance, so uremic effects on the heart, and also volume is better controlled, compared to dialysis. So, but after a year, usually there's no change on that, and it actually starts to increase again. They randomized people to fistula ligation or no intervention, and they used the MRI, cardiac MRI, which is a gold standard for calculated left ventricular mass. So you can calculate very accurately, how many grams is the left ventricle, much better than echocardiogram. So they did the MRI at the time of involvement on everybody, and then they ligated the fistula, and then they did repeated MRI on everybody 6 months later. The primary outcome was the change in left ventricular mass. Did it improve? Did it not change? Did it go up? And then secondary outcomes were change in left ventricular volume, in the right atrial areas, EF. They looked at proBNP, cardiac output, cardiac index, brachial flows, and pulmonary artery velocity flows.
So they took all comers? Just anybody who was a year out?
There were, inclusion criteria. And age more than 18, they had to have functioning AV fistula. They had to have normal, stable kidney function. And that meant that they couldn't have had more than 5 cc decline in their GFR over the last year. So really very stable. Then they had to be low risk of graft failure as deemed for their treating nephrologist, and then 12 months or later after transplant. Only people who had fistula in their forearm or in their upper arm. No thigh fistulas or things like that, no grafts. So this is how it worked. So they enrolled 93 were assessed, 29 were excluded, 64 under randomization, and so 33 assigned to have intervention and 31 assigned to control group, and then in the end they had 27 in each group to analyze. So the study plan is very simple, clear, and I think pretty genius. So they checked their baseline cardiac magnetic resonance. They did IV fistula ligation or no ligation, 2 groups, and then repeated cardiac MRI 6 months after intervention or no intervention on everybody. So they used the radiologists, independent radiologists, and they were blinded to whether people had intervention or not. Each MRI was read by 2 radiologists separately so that they get the same number. And then they were blinded to the initial MRI results when they read the second MRI results. That's what I said. Now, these are the patients, their baseline characteristics. So they were, I guess, pretty typical age for a transplant patient, around 60 years old. There were no differences in both groups on all the characteristics. More males. So the median duration between AV fistula creation and kidney transplant was about 20 months, less than 2 years. So it's not like some people had that fistula, for like 100 years and some for like 2 months. So I guess that would affect the outcomes as well. And then they were median between fistula creation and the first scan was about 8 years, or actually 7-8 years. Median time from initiation to initiation of dialysis to transplant, 18 to 50. So the median time from their transplant to the study start was about 7 years. So they've had that kidney transplant for 7 years, very stable transplant patients that had transplant for a long time. Now, diabetes, not that common, I guess. Yes, people are healthier in Australia, but about the same amount of people had diabetes and hypertension, smoking, peripheral vascular disease, ischemic heart disease, and then location of a fistula was pretty much 50-50, forearm or upper arm, and then immunosuppression was also similar, and ACE use and beta blockers and statins. Uh-huh. I think so. This was, I mean, I can I didn't check these numbers. Yeah, I can calculate. So 31 in one group, 32 patients in another group. I mean, we can check.
What he says is there's no way the p-value can be 0.07 when it's 2 and 2, and they're exactly 2.9 or something.
I haven't checked the accuracy of the calculations.
Well,
my disclosure.
Well, that would have been a Manwit EU because it's a.
Technically, it's still not.
No. You guys all misinterpret that significance to not significant. The probability of seeing that result is 7%. I don't believe it. That's what that means. It doesn't mean it's significant. It doesn't mean it's not significant.
But I agree. It doesn't make
the next
sense.
line also is.
It's
Yeah,
231.
I think there's an error in their table. And,
Do most
I think it was
patients
0.7.
who get a
16 people
transplant have a fistula versus a graft or a?
I didn't look into that.
I'm just curious.
Yeah.
I mean, it seems like it's like
Yeah, we haven't looked. Actually, it's a great question. That is fun to look up. Another project for nephrocardiologists.
Don't worry about it. Don't worry about it. The data's
But that's a really good question, actually. Yeah. You know, these are like better people from the ESRD group, but some of them are preemptive, you know, and when they come, they expect to get a kidney and they hold off of a fistula. So that is also interesting to look into. Yes, and I'm on the list, so I'm not going to get a fistula.
But that would be kids. That's like a big adult.
Shakespeare would say nothing.
We should email them.
How good their data is. Okay.
We should write an editorial.
No, I mean, it is weird, right? It is. Continue on. I think it's just weird that only 30%.
You guys aren't even hitting on the thing that I find the most.
What? That only 30% are on account. Oh, okay. Continue on.
It's Australia. It's kangaroos and crocodiles.
They're all on foster.
What's
disturbing to me? They're still functioning.
Oh yeah. Oh, that's not disturbing. Yeah.
Are our patients?
Yeah. Oh yeah.
Actually, it's about the average for a fish.
Continue on.
Grafts are about 3 years.
So now.
No. Primary patency versus secondary.
diabetes.
I thought the mean time to first procedure in a fistula was like 6 months. So if you put a fistula in somebody 7 years later, it's going to still be functional.
Yeah, it's a good
Did you say primary fistula?
Oh, I don't know. Well, I'm just making the assumption. Well, even secondary, if you have somebody who has a you have to go and fix it. You're going to get another stenosis, and the time between that stenosis and the next one is going to get shorter and shorter.
But on the other
That could
hand,
be that
But
these
you
are-
don't know what happens to fistulas when people have a transplant and they're not being stuck all the time, and their hemodynamics are beautiful. They
But
don't
that's
drop their
why-
blood pressures on dialysis.
In order to get a transplant, they eliminated all the
So you can't
diabetics and,
extract your
you
data
did.
to these
I mean,
people.
there's only 20% diabetics.
But you know, it like
Yeah.
gives a lot of things to look at, like actually your discussion. So the statistical analysis is on my bucket list to figure out like what these things mean. But Michael said that
they're
this
fine.
is all fine. So this is fine. They did the right statistical analysis. I'm going to learn it one day. So this is more statistical. So, yeah, but Mike said it's fine. The
Nephrocardiologist status.
yeah.
Yeah, the only thing I had a problem was with the use data. That's for their statistics. They didn't have real statisticians, and otherwise they'd use SAS.
Oh,
Seriously. No.
go ahead, continue on.
So the primary outcome, so the primary endpoint showed that the that the left ventricular mass decreased significantly in people who had ligation of a fistula by 22 grams. And like 22 grams, is it significant or not? So just for the reference, in the normal in men ventricle should be 121 grams on average, and then in women 83 grams. I got it from a American Heart Association trial, study. So this is not from Google search, which I do sometimes, but so 22 grams is pretty significant, right? In the ligation group, but there was no significant change in the non-intervention group. It actually increased a little bit over that period of time, but it was not statistically significant. So on average, it increased by 1.2 grams. Yeah, so, and, we looked at it. So, sometimes like when you say on average, it might be that like in one patient it reduced quite a bit, and then all the others didn't decrease, but actually we looked at it and actually it decreased in everybody except for one patient in the intervention group. This is now all the primary and secondary outcomes in this chart. So some secondary outcomes were statistically significant and some were not. So mass, the primary outcome, was definitely statistically significant. So this is control group. The mass of the ventricle didn't decrease, it actually increased a little bit. And then in the control group, it definitely decreased. Mass index, it's adjusted for the body mass, also significantly down. And diastolic volume decreased. And LV EV also decreased in the group. There was no change in the ejection fraction. So in this group, they concentrated on people with normal ejection fraction. They didn't have actually high output failures. These were not megafistulas, so it's not exactly like my patient. In mine, I'm hoping that it's going to slow down. Cardiac output actually decreased in the intervention group. But it's not like they developed heart failure, like their blood pressure didn't drop, they didn't get, actually their hemodynamics improved based on their filling pressures of the ventricles. So it's a good thing. Their heart doesn't have to work that hard. Index also decreased statistically significantly. LA volume decreased. Pulmonary artery velocity also. So this is the same basically as pulmonary artery pressures. They decreased. It didn't reach statistical significance, but it did go in the right direction. And it surely went not in the right direction in the control group. And the blood pressure didn't change significantly. It was well controlled before and it was well controlled afterwards. And there was no change in creatinine, but to begin with, creatinine was normal. And GFR hasn't changed. And it was pretty good for transplant patients. And pro-BNP actually decreased quite a bit. So pro-BNP basically is just shows you the stretch of the heart, like the volume, if the right ventricle, right atrium is overloaded. So it went down. Mm-hmm. Oh my. More. Okay. Mm-hmm.
What was the one that had the
patient care?
baseline characteristics? just curious, you're better on the outcome side of here.
Maybe it's a history, like, so it's controlled, but like if they're on medicines, you say that patient has hypertension. Like in my notes, assessment and plan, if my patient is on 3 blood pressure medicines, even if their blood pressure is 120 over 80 in the clinic, I still say that they have hypertension, right?
Back up to
Well, it looks a little bit better, 127 versus 134. But they didn't, that slide didn't say the control of blood pressure difference. It's just the fact of having diagnosis of hypertension, yes or no.
Actually, this is where they actually did the wrong statistics.
Oh, shoot.
It should have been a two-way analysis of variance with the factors being baseline follow-up and group. That way you could have seen if there was some kind of differential effect between, so the hypothesis is that their baseline blood pressure should be the same, although they're a little bit, and that
got it.
Well, they both stayed the same, so essentially, so that's a failure.
Yeah, so they didn't. Yeah, I see what you mean. They didn't include this as a variable blood pressure control. They should have. Yes, got it. Now the other treatment effects. So you ligate it, but you want to know if it's safe. So 6 people had pain erythema after the procedure, and they said in the article that it went away with non-steroidal anti-inflammatory medications. Not recommended. Then 2 developed infection over sutures with result of oral antibiotic, and nobody required reoperation or readmission. There was no change in eGFR, and none of the people required modifications of antihypertensives, and none of the people actually went back on dialysis during the study period. Now discussion. So this is not the hard endpoint. I guess people always want hard endpoints like death or going on dialysis, kidney failure, or MI or something like that. But I think just looking into the literature on this, left ventricular mass is probably as good as it comes for surrogate for endpoints for cardiovascular mortality. So there are a lot of publications and evidence in good journals about how left ventricular mass is associated with cardiovascular mortality, both in general population and also in ESRD patients. Didn't see much on the transplant patients on this, so maybe something also possible to look at. So we don't have hard endpoints, MIs and deaths, but I think we have the surrogate measure, what we have to have. So the other thing, I mentioned that before, but they did the intervention 8 years after the transplant, so you can't say that it's the transplant itself that is contributing to this improvement in left ventricular mass, because the improvement that happens from the transplant itself is within first year. After that, the left ventricular mass, they're not uremic anymore, that's it. And the control group actually didn't improve, they got worse, and the intervention group improved. It's not like the control group stayed uremic and the intervention group became non-uremic. Does that make sense? Yeah, so, and the limitation, again, we don't have the hard endpoints. I don't know. I think if we would have to email. Yeah, actually really interesting because it's 2 years after that study. Yeah.
Yeah.
There is yeah. I will email the, yeah.
Outreach.
Yeah.
The problem with hard endpoint is that you have to have it.
Or follow it for so long. Yeah. Mm-hmm. And it's actually surgical intervention, not a pill or something like that. So now discussion, so do we start ligating all kidney transplant patients fistulas at 8 years? And probably not yet. But the things are changing with transplant a little bit. The survival, like 5-year survival in transplant patients is improving. So transplants are working longer. They're not failing so fast. In United States at 5 years, in 2010, it was 73 and 85. It's probably better now. I didn't pull that statistics for cadaveric and living donors. And also, the most common cause of graft failure in transplant patients, do you know what it is? Yeah, deaf functioning graft. And the percentage of these people keeps going up and up. So deaf function, so they die, and they still have that fistula, and they never needed it to use. So things are changing, and I think things are changing towards the conclusion that maybe in some people we should tie them off. So for now, what I do is, I always look at their fistula. If it keeps growing bigger and bigger, sometimes I order like the flows or the echo, or especially if they have symptoms, or if they have unexplained creatinine fluctuations, because they get cardiorenal syndrome. We did a huge favor to 2 people ligating their fistulas in this case. We had a lady who kept being readmitted with AKI. We would have to diurese her. We would optimize her. She would get better. And then again, she gets AKI, horrible AKI. And I'll see what happens. So Dr. Davidi saw this patient yesterday, and he scheduled the ligation. So I'm really curious what's going to happen to her. I'm sorry? I didn't check the flows. It's huge. No, she was private, but it's Miss Spalding. It was yours, or? Yeah. Yeah. I think she was private, and I tried to send her back. Yeah, she was private, but she doesn't go to her nephrologist.
So, I mean, if I saw this data.
Oh yeah, we ligated.
Yeah, I never lost it. So, especially, there's this benefit. There's also the benefit of not working.
So the other precaution they took is, when the surgeon saw them initially for consultation for ligation, they they did venous mapping to make sure that there is good vasculature for future fistula. If they didn't have, they excluded those people. So, you would.
Interesting you say that, because I was kind of wondering, showed the exclusion.
I did, yeah. They are in the article, which I haven't printed. Well, only Michael has. But it's exclusion. Yeah, if they don't have good vasculature for future fistula. Oh, I don't know. It's so rare, probably angiosarcoma.
I was wondering if ligating that then it's soft argument for ligating them. I guess if it increases the risk, then that's a consideration.
So yeah, the first time I did it, I was like, oh my gosh, I was freaking out. Because when somebody gets AKIs, like her AKI would be like trying to go into 4. Is she gonna need to start dialysis, and then I'm gonna have no access? But the cardiologist, but you have to call them and talk to them. You can do so. It's really helpful. So what Dr. Elkirsch used to do, he's gone now, unfortunately, but what he used to do for us, he would do right heart cath, and at the time of right heart cath, he would occlude the fistula and see how much the cardiac output drops and how much the pulmonary artery pressure drops. He did that study, and in that lady, it improved significantly. Not Elkirsch.
That was with the PA pressure.
PA,
right?
yeah.
When he was doing the right heart cath.
I spoke with, I did it with cardiology too, like, oh my God, a lot of talking, like this, the nephrologist calling, telling them stupid things, but like to hold the fistula for a little bit and do the echo and just to see also what their RSVP does with it.
Well, he hasn't published anything in fall.
That was the problem, right, because of COVID. This 2019.
I can email them.
Do we have a protocol?
No. But if I start including everybody, we'll get like clotting fistulas.
Yeah.
No, I would rather just go case by case. Yeah. I just call. They have my number, then they call. What do you want to do? They're like, do I put Turdicaine on? I'm like, no. Yeah. Thank you.
All right, thanks. Yeah.